Hello, everybody. Thank you so much for joining us today. My name is Frida Pineda, and I will be helping moderate for today's session. Today, we're going to be presenting on improving cultural competence and humility in diabetes care, brought to you by the National Center for Health and Public Housing. So before we get started, these are just a few housekeeping items that we're going to go over. First of all participants are muted upon entry. Please make sure that you also engage in the chat if you have any questions, any comments, or any promising practices that you would like to share with us regarding today's topic. Also, make sure that you raise your hand if you would like to unmute your line. This meeting is also being recorded, and the slides and recording link will be sent via email after today's session. So for today's webinar, we're going to have some interactive questions. And in order to prepare for that, please go to menti.com. We're going to be using Mentimeter. So go to menti.com and enter the code 76575645. Or you can also use the QR code that we have on the screen and scan it with your smartphone or tablet. We're gonna give everybody just a few seconds to enter that information. Okay. So for today's speakers, we have the company of Dr. Jose Leon, who is our Chief Medical Officer at NCHPH, and also myself. My name is Frida Pineda Sandoval again, and I am the Training and Technical Assistance Manager. And we also have Chantel Moore, who is our Communication Specialist. The National Center for Health and Public Housing is supported by HRSA and is also part of the U.S. Department of Health and Human Services. And the information for today and conclusions are those of the author and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA or the U.S. government. Also, the mission of the National Center for Health and Public Housing is to strengthen the capacity of federally qualified health centers and also federally funded public housing primary care grantees by providing training and a range of technical assistance. So now we'll pass it on to Dr. Jose Leon, who will continue with today's presentation.
Thank you, Fide, and good afternoon, everyone, or good morning, depending on where you are in the country. It's such a great pleasure, and I'm very honored to be part of this conversation on cultural competence and cultural humility. This is a very important topic when we discuss some issues, some chronic medical conditions affecting those being served by community health centers in general, and specifically when we work with health centers located in or immediately accessible to public housing. According to the UDS data, in 2021, over 1,300 health centers provided services to over 30 million patients. 458 of these community health centers are located in or immediately accessible to public housing. And in the same year, they provided services to 7 million patients. 108 of these health centers located in or immediately accessible to public housing received funds from HRSA to provide services to those living in public housing. And in the same year, they served over 900,000 patients. The map on your right-hand side shows the allocation of the health centers and the public housing developments in the United States. If you would like to access this map, you can go to our website, www.nchph.org, and go to interactive maps, and you'll see this map and other maps specifically on chronic medical conditions affecting those living close to or immediately accessible to public housing. Next slide, please. Before we get into the nitty-gritty of this conversation, is very important to go over the public housing demographics because we'll see how diverse is the population living in the public housing developments across the United States. According to HUD data, the most recent data that we have available is from last year, and 1.5 million people lived live in public housing developments. According to the same report, there are 38% of those living in public housing have one or more disabilities, either physical or mental disability. 52% of them are white, 43% are African American, 26% are Latino, 19% are over the age of 65, and 36% are under the age of 17. Next slide, please. It's important to discuss cultural competence and cultural humility, not only in public housing, but this is related to all the populations being served by community health centers. Just a brief overview, we know that HRSA has 3 special populations. We have people experiencing homelessness, people living in public housing, and migrant and agricultural workers. So for those living in public housing, diabetes is and continue to be one of the biggest health concerns, not only for HRSA, but for HUD. And there is a document, the health picture of HUD-assisted adults. And according to this document, over 17% of those HUD-assisted adults have diabetes and other chronic conditions such as COPD and asthma, and over 71 or around 71% are either overweight or obese. So as we saw on the previous slide, we also know that 26% are Latino and around 43% are African Americans. So it's really important to make the connection between diabetes and cultural competence in this special population. The other one that is really important is the migrant and agricultural workers. And we know that some of the health centers serving public housing residents also serve those migrant and agricultural workers. So it's really important to understand the cultural background of the populations to address any of the chronic medical conditions affecting these populations, because we can have a very well-established treatment protocol, diet, a nutritionist working with all of them, but if we don't understand the cultural background, it's going to be very difficult for us to manage not only diabetes, but any chronic medical condition in general, like cardiovascular diseases, or whether or not this patient can reduce weight because the patient is overweight or obese. So this is we need to see the patient as a whole. And if we are able to understand the limitations and the background characteristic, cultural characteristic of our patients, then we will be able to address any chronic medical condition and improve the health outcomes of the populations that we serve. Next slide, please. So today, we are going to define cultural competence and cultural humility. We are going to have a brief discussion on barriers to the provision of high quality care in patients with diabetes. And we are going to identify some cultural competence resources for health center staff. Next slide, please. And I'll turn it over to our communications manager, Chantel Moore, who is going to guide us through an interactive activity. Chantel?
Thank you, Dr. Leon. All right, everyone. So what we're going to do today is we're going to look at an interactive map, and you are going to pinpoint various countries that you have visited in the past. I'm going to share the link to the interactive map in the chat. and I am going to give you a visual display of how you will complete this. Okay, so whenever you access the map, what you will do is you will simply click the white plus sign in the bottom right corner and then type in your location and press enter. What is going to happen is it's going to zoom into your location, but you can easily zoom back out. And after everyone completes this, we will go over our findings.
Also, if by any reason you don't have access or you cannot access this platform, you can also use the chat and just type the country that you have visited or countries that you have visited. That's another option in case you don't have access to Padlet.
All right, Dr. Leon, Fide, we've got a lot of visitors going to share our screen. So we have lots of people who have visited France, Jamaica, Baja California, and Mexico, Spain, Milwaukee, Bolivia, Mexico again, and Guatemala, Panama, and Honduras.
Excellent. Thank you so much for sharing that. And I see some people who use the drag and drop, and I see France and Spain as well. Chantal, I'm not sure if you mentioned those, but it's important for everyone to get some awareness about culture, about cultures. Specifically, when you visit another country, you'll see some things that are similar and others that are a bit different. And it's going to increase or improve our knowledge of the culture of people that we have contact with. Specifically, we deal um, uh, with the public in general, either at the health center or if you go to a supermarket or if you go into the community to any place, you will find people from different background and nationalities. And even though we all are Americans, sometimes we have different backgrounds. So it's really important to understand this piece in order to provide better services to our patients in general. Next slide, please.
Okay, so now before we continue, we're gonna do a very short activity. This is gonna be just an icebreaker. And based on the responses that you provided, Chantal is going to also ask some questions, and then we're gonna go over the answers. And this is when we're gonna be using that Mentimeter option.
Okay. Okay, everyone, so just briefly before we begin, our entry code is 76575645. All right, so in your last experience visiting another country, What did you learn about their national dishes?
Okay, so as we have these responses coming in, I'm going to read them out loud. And we have some responses that say they eat a lot of carbs, the variety within one country, the process of preparation was important in detail, okay, and the ingredients used in regional cuisine. Similar to my culture, but with a twist, okay. I'm curious to know. You're more than welcome to also put in the chat where you're from. That would give us an idea as well. Less processed foods, smaller portions. Okay. Almost all food was sourced locally and most meals were prepared rather than fast food, eating processed foods. The sweetness in the dishes. Okay. All right, Chantal. So I think we have, oh yeah, we have one more response. Delicious, carb, greasy, less processed. Yeah, I do definitely see the pattern that the foods are less processed in other countries. Well, thank you everyone for your responses to the first question.
All right, we'll proceed to the next question. In your last experience visiting another country, what did you learn about cultural differences?
So for our first response, we have volume of voices when communicating. They value their history and elderly family members more than Americans. And then we have one in Spanish that says, tantos idiomas que tiene Guatemala que son de verdad hablados. Translation saying that Guatemala has a lot of different languages. And family values, yeah. Families live together no matter the age. All right, Chantal, I think we can move on to the next question.
All right.
Thank you, everyone, again.
Our next question. In your last experience visiting another country, did you experience a language barrier? And if so, how did you overcome it?
All right, so we have some responses. Google Translate, that's a good option. I was much younger, so my parents translated. And yes, body language and smiling, it works. always works, a good smile. Acting out my words. No countries. I have visited, no both English or Spanish. Okay, that's good. Okay, thank you, everybody. All right, so now we're gonna continue with our presentation for today.
Well, thank you so much, everyone, for participating. It's really interesting to see the responses and some of the cultural differences that you noticed. And sometimes we go out because we have some time off and we go on vacation and visit a country for a week, couple of days, and we encounter some of these difficulties. We noticed that some dishes are different. I was really interested in seeing some of your responses, like the amount of carbs, that some cultures that they go to the supermarket or the market daily so they can eat fresh food, that they eat less processed meals, or they don't eat too many fast food dishes. And in regards to the culture in general, impressed to see all the issues, all the thing that is related to how in other cultures family is very close together, and the young people take care of the elder and those who are the leads of the families sometimes, and of course everything that is related to the how we interact with people. Now that happens when we go to a country just for one day or for a few days or a week. Can you imagine coming to the United States and having that difficulty every single day until you are able to absorb a new culture and interact with other people living in the same community? So this is going to be a process, and people are not going to change their culture or the cultural background in 1 or 2 days. Is going to be a process. So we need to be very aware of those changes, and we're very respectful to the newcomers, or the cultural patterns or cultural differences in the people who live in our communities. Next slide, please. So this topic is extremely important because the US population is changing, is evolving. We have, according to the US Census Bureau, by 2050, over 50% of the population in the United States will be very diverse, and we will have people from different racial and ethnic backgrounds being in the majority. So we are going to change from non-white populations to other race and ethnicity, races and ethnicities. So this is going to be important and will cause an impact on the way that we interact with our patients in the community. And since we are always evolving and we are always learning, we learn new protocols, how to manage diabetes, how to manage cardiovascular diseases, how to manage hypertension. Now we are addressing social determinants of health. We are making sure that we provide the referrals to our patients. And now, since our population is changing, we also need to be learning. We also need to start learning about cultural differences and making sure that we are humble enough to understand these differences. Next slide, please. So this is a case presentation and it's going to dictate somehow the next few minutes that we are going to have this interaction. But this may be something very familiar for all of you. And Maria is a 57-year-old Spanish-speaking woman with a medical history of type 2 diabetes, hypertension, and hyperlipidemia who presents to your clinics to establish care. Through an interpreter, you learn that she immigrated from Mexico to the United States 2 years ago and lives with her children and grandchildren. This is her first visit to a doctor since she moved to the United States. Maria ran out of her medications about a year ago and reports feeling excessively thirsty and fatigued. She also reports that she wakes up several times each night to urinate. She's worried about her diabetes. Her sister, who still lives in Mexico, recently had to get her foot amputated as a result of diabetes-related complications, and her brother just had a stroke. She takes a daily 30-minute walk around the neighborhood, and her diet is a mixture of traditional Mexican foods such as tortillas, rice, and beans, and a typical Western diet, including fast food and processed snacks. In the clinic, Maria's fasting blood glucose is 220 milligrams per deciliter, and her blood pressure is 148/95. Her physical exam is unremarkable, and laboratory test results are pending. Next slide, please. So we have another activity. Chantel is going to lead us through mentimeter.com again to answer the questions that we have on this slide. Chantel?
Thank you, Dr. Leon. All right, everyone. So if you all would not mind just going back to menti.com, I've also placed the number in the chat as well. It is 7657-5645. All right, so opening with the first question. How can your health center best address Maria's needs in this scenario?
All right, so based on the responses, we have contract an interpreter, give her options of a healthy diet to follow. See if we get any more responses. Help her get signed up for insurance, work with her to obtain affordable medications, use interpreter to educate her on diabetes. And offer modified recipes for traditional dishes to help her reach her goals. We also need to give nutrition education, cooking class that will show her how to cook new recipes, connect her to a low-scale fee health clinic. That's true. All right. And Dr. Leon, what is your feedback regarding these responses?
All these are excellent responses. So if we go back to the case study, we know that Maria is from Mexico, that she only speaks Spanish, that she has family history of diabetes. And according to her last blood work, the fasting glucose is high. And she also has some issues with her diet. So all these responses are the exact responses that we are looking for. Is completely important to establish a good relation with Maria through an interpreter. Going back to the Hispanic culture, sometimes they always go with a family member who speaks English. So this is something that you'll see. And for some clinics, it's better to have an interpreter. So there is, in case there is a question that sometimes Maria or the patient doesn't want to answer because a relative is very close and they don't want them to know specifically what the issue is. So you need to make sure that you address all those issues. I agree with the medication reconciliation. Let's remember that based on the case study, Maria hasn't been visiting a clinic for the last 2 years since she came into the United States. So all these are really good answers.
Perfect. Thank you so much, Dr. Leon.
What cultural aspects are important to recognize and incorporate into her evaluation and care plan?
Okay, so far we have 3 responses, her food preference. We have another participant that said, right to free interpretation resources, the preparation of food for her family.
These are really good answers as well, as we learned. We're still having some answers here.
Yeah, we have 2 more. She doesn't need to change the diet. Respect, just to manage the portions and include more vegetables. Okay. We also have to consider things that are important to her in culture and maybe religion. Language and different nuances of communication, diet, family involvement, her experience in a new country. That's correct. And consider how much time she has for meal prep.
All these are excellent answers as well. I like the one that we have in the middle, that we have to consider things that are important to her in culture and maybe religion.
Mhm.
Specifically, we are going to briefly, we're going to discuss that in some cultures, herbal medicine and traditional medicine is extremely important for some of these cultures, and the religion portion as well. So there are several words that probably we are not familiar with, but there is one in particular that when you talk to people who are either agricultural workers or new migrants, they talk about fatalismo, or something that is fatal, of fatalism, which is basically, this is going to happen to me regardless of what I do. And so those are things that they have learned in their culture, and things that we also need to address, be very respectful, but at the same time address them, and making sure that they understand that this is a disease, that this is not something that has nothing to do with anything that we have done wrong in the past. So those are things that are really important that we learn and that we notice when we have a conversation with those people from different cultures.
What is cultural competency and cultural humility and why should health centers care?
All right, I don't see responses for this question, and that's fine because that is what we are supposed to learn today. But I see this one, learning about someone's culture and giving it respect will grow trust with your patient. That is correct. Peter, you can keep.
Yeah, no, definitely. I mean, I think this question is, you can have different answers for it. So that's why it takes a little while to get responses. There should be a holistic approach. Culture is a major component for sure. And it's one thing to recognize cultural differences. With that knowledge, we have to respect the importance of various cultural practices. This fosters a better relationship with patients. That's correct. Yeah. And I think from the top of my head, what I can think of, Dr. Leon, also is cultural competency is like when you have, as a provider, when you have the ability to take into consideration the other person's cultural backgrounds when providing treatment.
That's right. I mean, cultural competence is a set, you know, of patterns in one culture that we know that somehow impact how a person is behaving, right? Whereas, and as you said, cultural humility is the ability, you know, to understand them and making sure that you practice, you know, this set of values that you have learned from others. So let's go back to our presentation. We are going to learn now, and we are going to address our very first objective about what is cultural competency or competence and what is cultural humility. There are several definitions, and I found two that, in my opinion, are the best responses, you know, to this particular question. In regards to cultural competency, is the integration and transformation of knowledge about individuals and groups of people into specific standards, policies, practices, and attitudes used in appropriate cultural settings to increase the quality of services, thereby producing better outcomes. Cultural humility combines the lifelong process of self-exploration and self-critique with a willingness to learn from others. It promotes interpersonal sensitivity and openness, addresses power imbalances, and develops an appreciation of intercultural variation and individuality to avoid stereotyping and have a more oriented perspective. So we had these interactive activities because through the questions that we discussed, we learned about cultural humility and about cultural competence. We went over the exercise. Hey, what countries did you visit? What do you learn about that culture? So you were, without knowing, you were just processing the information that is here. Sometimes when I read a definition, it's difficult to understand it because it has some words that sometimes do not make any sense. But when you put these words into practice, you see that if you see that the family values, the religion and cultural beliefs are important in other societies or in other countries, you are learning the definition of cultural competency. If you are able to digest those new or the new knowledge that you have and put that knowledge into practice, you are practicing cultural humility. So throughout the exercises that we did and the interactive activities, we learned two really interesting definitions on cultural competency and cultural humility. Next slide, please. Now, why is so important to discuss cultural competency or competence and cultural humility in diabetes care? Well, couple of things that we need to keep in mind. Diabetes is a HRSA priority. We've been working with health centers, and health centers have been working with patients with diabetes and A1Cs for the last few years. In fact, some health centers, when they had their site visit, one of the quality measures that were addressed by those performing the site visit was to check the A1C and what strategies, what promising practices, what evidence-based activities you are doing to help the population that you serve. The other thing that is important and that we also discussed is that the population in the United States is changing. We saw that by 2050, over 50% of those living in the United States will be non-white, and that will be from different backgrounds. We also know that minorities in general are more affected than whites when we talk about the incidence and prevalence of diabetes in the United States. That these minorities not only have diabetes, but they are more likely to have uncontrolled diabetes. And important enough, we are talking about incidence and prevalence, but as we will see, mortality rates due to diabetes are higher in those racial and ethnic minorities. So we need to make sure that we understand those issues affecting our patient, and at the same time, something interesting that is coming from the American Diabetes Association and specifically from their standards of care, that we have some BMI, and we say, oh, you know, your BMI is high, so you may have you will be more likely to develop diabetes. And in some races, and specifically in some groups like Asian Americans, the BMI, we can have people with diabetes even with lower BMI scores. So let's keep that in mind, and let's make sure that we understand those differences. Next slide, please. Just to go over some of the patient characteristics on diabetes and why it's so important to address both issues. You know, and this is the latest report from UDS 2021. You see that over 1,300 health centers are reported in 2021. Over 30 million patients were served by these health centers. And there are two groups that we need to pay attention to. One is the total number of agricultural workers and or dependents. Over 1 million patients were served by community health centers or FQACs. The number of patients with diabetes, before that, the patient best served in a language other than English. So in the same year, over 7 million patients were better served in other language than English. That is almost 25%. 1 out of 4 patients that are seen by health centers prefer to be served in another language than English. Then the number of patients with diabetes is almost 3 million patients. That is about 9.5%. The estimated number of Latino patients with uncontrolled diabetes is or over 34%. The estimated number of Asian patients with A1C is over 21%. And there are others who refuse to report race and ethnicity, and those are 37%. And we know sometimes that these patients don't like to be or don't like to report this because a stigma can be another issue, and they don't want to be stigmatized just by report race and ethnicity. So this number, the patients, better served with in another language other than English, which is around 25%. That number can be even higher based on the unreported or refused number to report race and ethnicity. Next slide, please. So there is a really difficult process here, and we need to understand that health centers in general are going to first be dealing with patients with diabetes. Diabetes is increasing every time that we see the new reports coming from the Center for Disease Control and Prevention. There's the report from the health centers. The number of patients with diabetes is always increasing. At the same time, the number of patients from different backgrounds, specifically related to race and ethnicity, those are always increasing as well. So we need to make sure that we address both issues, and that this is just related to the prevalence and the incidence of the disease. When we see mortality data, which is another big issue and that we need to keep into consideration when we discuss cultural competence, we know that there are two conditions that are the main two conditions, when we're discussing causes of death. One is heart disease, the other is cancer in the United States. For a couple of months or probably a year, COVID was one of the main three. But anything that is related to cancer, stroke, or heart disease are the main causes of death. But let's take a look at diabetes on this slide. When you move, if you look at the very first column, they are ranking the causes of death. So in general, when you go to probably under alls, diabetes, complication of diabetes is the 6th or the 7th cause of death for all races. But when you start looking at African American, for instance, in patients who are African American, and female patient is the 4th cause of death. Is the same for patients with who are Asian or Pacific Islander, and for Hispanics. So we see that people from these minority groups are more likely to die from diabetes complication when you compare them to the general population in the United States. Next slide, please. So again, the importance is that, as we have discussed, and this is just a reminder that what we have been discussing, that the population in the United States is changing, that the racial and ethnic minorities, and that is highlighted in yellow, the higher prevalence of diabetes at a lower BMI, is seen in those who are from racial and ethnic minorities, specifically Asian Americans. So we need to keep those cultural differences in mind when we discuss all these issues with our patients. Next slide, please. So related to the BMI, these are the current American Diabetes Association guidelines when we are discussing BMI. And for patients with diabetes, if you are screening a patient for diabetes who is asymptomatic, the BMI has to be over 25 kilogram per square meter. Yeah, but for those who are from Asian Americans, you need to start considering risk for those who have a BMI of 23. So in general, ADA set a lower cut point for Asian American to address evidence of disparity, showing that the higher BMI would miss approximately 36% of diabetes cases among Asian Americans. So let's keep that in mind, because we're just saying we cannot put all these patients in the same bucket. It's like, okay, you are lower than 25%, you're fine. I mean, we are just screening you for diabetes and your BMI is 25. Probably that's not the case. According to the American Diabetes Association, if the BMI is lower than 25, or and they are setting 23% for this particular population, because those two percentage points can make a big difference, because you can miss a diagnosis of and approximately 36% of those patients with a BMI who is between 23 to 25. Next slide, please. In regards to some resources, there are several resources that we can go. There are universities. The American Academy of Family Physicians has the Everyone Project. The U.S. Department of Health and Human Services Office of Minority has a physician practical guide to cultural competent care. Georgetown University National Center for Cultural Competence has the National Center for Cultural Competence, where you can go and get as many resources as you want and adapt them to the needs of your health center. Now, there is another one that I really like, and is the HHS's ARC, of the Agency for Health Research and Quality. And if you go to their main website and type cultural competence, you'll see many resources in many languages that they have and they have been developed based on evidence-based practices. So let's make sure that we go and visit these resources, because this is an important starting point in case you need to train your staff on this particular issue. Let's keep this in mind. In order to make changes in cultural competence and cultural humility, there are three types of changes that we need to reach. First is we need to train our providers and our staff on cultural competence, and that is a very that is at the individual level. Then we have the clinic level, where we can go and train and get any of these toolkits and just provide some training to everyone. But we also need to educate our patients on cultural competence issues, because those who are from a racial or ethnic minority can also be stigmatized and feel that they are being stigmatized, and just make sure that they also understand the cultural differences, that they understand that because I am Hispanic white, there are some differences if you are from Haiti and you are if you are Black, even though we are talking about probably two different languages and two different countries. There are people from Peru or people from Colombia who are also Black, you know, and those differences can make a change, because as somebody noticed and mentioned in one of the one of the exercises that we had, they mentioned that among these groups, there are some subgroups, you know, and there are some nuances and some minor differences that we also need to take into consideration. Next slide, please. So from a provider's standpoint, there are a couple of things that we need to make sure that we understand, and these are some of the, there was a survey asking providers about diabetes and lifestyle changes. And for some for some clinicians, some patients do not care about their health based on this survey. And the others said there's for some of them it's difficult to follow treatment recommendation, and the only person that you need to blame is the patient and nobody else. Others said everyone understands what it means to have a chronic illness, and then not following providers' instructions means not adherence, and that's exactly what they said. But sometimes they didn't take into consideration whether or not they understood the patient needs, the patient culture, the patient food, the religion, and the access to healers, the access to those who like natural remedies. There is an organization in the United States, the National Institute of Alternative Medicine. This is an NIH institute, and the goal or the mission of this institute is to make sure that we understand some of the properties that are behind some of these natural remedies. So we also need to understand that people with diabetes in Mexico or Central America or America in general, they believe about the use of black tea or any herbal tea to decrease the glucose in their blood, and others use cinnamon, and we need to make sure that we also address those things when we have this discussion with our patients. Next slide, please. Let's make sure that when we are talking about diabetes, and this is probably our conclusion, that we have to have a team-based approach. We discussed the use of interpreters, the use of nutritionists, the use of patient-centered, high-quality care that we discuss with our team. Everything that is related to culture, and we train our CSWs and health system navigators and everyone on this particular issue, and making sure that we also address that there is always an opportunity to learn from all these patients. It would take some time to learn about their cultural background. Next slide, please. So in regards to Maria, this is just a conclusion of what you guys said in the very beginning. She needs a team-based approach. Everybody mentioned that. Everybody mentioned about the dietary recommendation for Maria, that she needs to use, and emphasize the use of the some of the ingredients in the Mexican food, like corn tortilla. But we can change, for instance, white rice for brown rice, and include some fruit and legumes and everything else, that we can also change and be respectful of their tradition and how they eat and what they eat. Review the individualized plan, and that's exactly right. Somebody mentioned that the medication reconciliation and making sure that the diabetes plan need to include family members, because in this particular population, that is extremely important. Next slide, please. So let's tailor each recommendation for each patient, and let's use the patient-centered communication style. Let's use an interpreter or a family member who speaks the language, and make sure that we address all these issues. Next slide. So thank you so much. I think we have probably 1 or 2 minutes for any questions, but thank you so much for attending this webinar. And please do not forget to complete this survey after this webinar is over. If you have any questions, please, you can ask your question either through the chat box, the Q&A box, or if you would like to ask a question verbally, you can also ask your question verbally. Today, you can take it from here.
Thank you. So far, we don't have any questions that have been submitted. But we do have a comment that says food culture is a hard issue in Puerto Rico.
Thank you,
And-
Francis.
Yeah, and then we have another question. What was the website for alternative medicine?
Great question. When we send the slides, we will make sure that we include the website where you can visit it. It's one of the NIH institutes. NIH has over 20 institutes. I don't remember exactly the URL, so we will send it to you after the webinar with the slides and the link to the recording.
Thank you. Also, thank you, Lisa. I'm glad that you enjoyed today's session for sure. We don't have any other questions in the meantime. But if anything,
Right. In case you have any questions, please make sure that you reach out to us, either Fide, Chantel, or myself. We can answer any questions. Also, you can visit our website, nchph.org. You will be able to find trainings similar to this one on different topics, or also publications on interactive maps. That is my contact information, and the next slide has our thank you. And again, thank you so much for attending this activity. And again, my email address is jose.leon, L-E-O-N, @namgt.com. And if you have any question or you have any additional comments, please feel free to email me. Thank you.
thank you, everyone. Have a great rest of your week.